Brilliant. Right, I'm going to kick off because your time is precious. And thank you so much for joining, and others I'm sure will join as they're coming on. Would you mind, just so we don't have loads of time and we've got quite a lot to pack in, would people mind just introducing themselves in the chat? That would be really helpful. Just who you are and where you're from, and if you wanted just to put a little bit of a personal thing of kind of why you wanted, you're part of this group or what you're trying to do or a challenge, you can choose what you put, but just something a bit personal in there, and also that offers people the opportunity to help you out if you've got any challenges. We are going to cover a few things today. So Ben has kindly joined us to share a bit of information about what the data looked like during the junior doctors strike, because it's kind of an interesting, you can't normally see what things are like without the junior doctors around, and what does that show? And so thanks, Ben, for joining for that. We're then gonna cover very quickly just the Hewitt report and how that's helpful to our work. Ros Young from the nursing director of Midlands is going to join a bit later to share kind of some updates around criteria-led discharge and clinical criteria for discharge as well. And then the other thing I'd love to pick your brains on and share a bit about is how people have been using the resources, the Tackling Harm Together resources so far, and if they're not, kind of why not, and what else would help. I'm very aware of a case in Barnsley where they've now used it for workshops, etc. So I can share like how that's gone with everybody. So yeah, that's it. So if without further ado, Ben, would you mind introducing yourself and firing away with your interesting news?
Thank you. I've just realised I'm listening to this without my headphones plugged in through the speakers. Ben Owens, ED consultant, Sherwood Forest. I'm an ESIS clinical lead, and I'm an ESIS clinical associate as well. I'll stick the slide straight up. So this is about. This for me is important because if we've got the data suggesting sort of 500 additional deaths in the UEC system. Due to delays over the last winter or last 6 months or so, and within the strikes, most hospitals significantly improved their OPAL status and their flow during that time. And clearly, there were lots of consultants around on days, nights, evenings, whatever else. Most referrals were given by or taken by a consultant, and clearly we can't replicate that. So that's however. The data to me is really interesting, and you can't replicate those conditions because it's impossible and there's training involved. But actually, if we could get 20 or 30 or 50% of the gains we got from this, it would be a very big difference in terms of delay, because most of those urgent care deaths are mostly put down to delays and harms related to those delays within the UEC system, be that ambulance, ED, on wards, all those things. So I will share screen if that's okay. If my computer's gonna play ball, come on. There we go. So the presentation is not finished. I'm trying to teach ATLS at the same time, so I do apologise. So I'm going to. It's a poor presentation, but I've run out of time. So basically, it's the two strikes. There was. I will just. So dates of the strikes: the 13th, 15th of March, and the 11th, the 14th of April. I'm going to skip a couple of slides to a busy slide, but I'm going to talk you through that busy slide because it's easier to do that. So what I've got here, and you should better see this. So we're trying to look at the data from the strikes. This is both strikes combined. We've got strike 1, which is the one in March, and we've got strike 2, which is one in April, and we've got non-strike. So the non-strike data is all the data in the weeks surrounding the strikes. We did look at it both for just weekdays. The strikes are on weekdays and weekends. It seems to make no difference to the numbers. So type 1 attendance, this is ED patients, not those streamed to primary care, not those seen in urgent treatment centres who count in the overall numbers. These are ones seen in an ED who, as long as we're streaming correctly, should be genuine ED patients. So the national, this is all national data for the site. This is the average number of patients per day. All this is the average for the day. So average number of patients per day in the non-strike week. Strike 1 was busier. Strike 2 was quieter. So strike 1 was actually about a 7% busier than the normal period of time around the strikes. Strike 2 is about 5% less busy. That's just the context for where we were, I think. 4-hour performance, which is obviously a measure of flow and efficiency within the ED, whether you like it or not, it's a measure of timeliness of care. So 4-hour performance in non-strike weeks nationally for type 1 patients, 61%. It was better, so 66%, so it was a 4% gain. That that's a 7% contrast gain. So that's it's a 7% overall, 7% better. Rather than change the percentage. So we have the percentage change is the change in the baseline was 61%. That is a 7% increase. So it's a 7% improvement against a 7% activity increase. And likewise against an activity drop in strike 2 as an 11%. So I put positive there. So the impact demand is as higher demand, we had a positive change. Second strike, lower demand, we still had a positive, but a bigger positive change. So a bigger shift in it. That makes sense. So 4-hour target improved. That'll be down to people being seen quicker, which I'll show you in a minute, and exit people leaving the system quicker. Ambulance numbers in the non-strike days is 10,000 average. Strike 1 is 11,000. Strike 2 is the same. So both strikes had higher than average, not lower. Didn't scare people away from ambulances. There were higher average ambulance demand on those two strikes. So the change was a 4% rise and there was a 4% rise. So both the demand for ambulance patients is higher and they're probably a fair proxy for acuity of patients coming into EDs. So about a 4% rise in patient activity. Handover activity, despite that higher attendances, was about neutral for the first strike, so 1% difference. But for the second strike, those ambulances who were over 30 minutes was better. So we had fewer ambulances over 30 minutes. That's a positive change. Does that make sense? So actually, ambulance turnaround time improved by ambulance delays improved by 27%. That's better. More people were treated quicker. Percentage of ambulance in delay, about a quarter normally, a little bit less, so about neutral in terms of the first strike, but actually there's a significant change at the second strike. So significant improvement in that. Patients seen with 1 hour in ED, average is 35, 40% in the first strike, 46% in the second strike, both are positive improvements. Bed occupancy, and this is interesting for me, average 93% on the non-strike days, very similar but slightly better in the first strike overall. But in the second strike, it was significantly better. So a 3% difference. When 3% bed occupancy is a big shift. And actually, really interestingly, this is not hospitals clearing out long stay patients. The number of long stay patients went up. So actually 51% baseline, 52% for strike 1, 54%. So this was not hospitals clearing out because of social care. One was groups around Easter, one was around. So actually this was not about a reduction in people who are in hospital for a long time. So basically, if we summarize that, we have an increased activity strike 1, decreased activity overall strike 2, but we have an increased ambulance activity, which is a measure of acuity in both strikes. We have a better 4-hour performance. We have a better ambulance turnaround time, with delays in the system. We have reduced bed occupancy, despite an increase in long stay patients. So that is a higher turnover. That can only be then a higher short stay patients. The other data which I've got from, which I think interesting too, was around investigations. So average number of investigations, non-strike days in ED, average number of investigations strike days was lower. Despite more ambulance patients, and this is the average investigation per patient, we did fewer investigations per patient despite more ambulances being present in both the two strikes. So actually senior presence meant we used fewer tests and discharged more people. And finally, third, this is a day-by-day analysis of strike 1. And what you've got basically is actually strike 1 improved. Bed occupancy, while it didn't drop, bed occupancy did improve as the strike went on. So actually, while there wasn't a significant drop overall, there was a gradual drop, and strike 2 was longer. So whether had strike 3 carried on, we don't know. Would it have got to where strike 2 was in terms of occupancy? But everything improved as time went on. I'll stop sharing there because that's the data. But for me, the thing in that is if we have higher ambulance activity, we have improved flow. You could argue more senior doctors, but most EDs have fewer staff on. We use fewer investigations. We admitted fewer patients. Our length of stay dropped despite long stay going up. We can't replicate the consultant presence on the ward like we did, but it's unlikely that consultants or senior registrar specialists doing TTOs made it better. It's unlikely them doing cannulas that made it better. And I think when you talk to nursing staff anecdotally, it was the speed of decision making that made the difference. So actually, a normal ward, a consultant comes in once a day, said, does a ward round, goes back, comes the next day. What they had on it, if anything occurred after that, a result came back, it was acted on by a consultant at the time in the daytime hours. That's what nursing staff fed back. So really, I'm interested in people's thoughts. We can't But as someone put in the chat, there's clinical criteria for discharge. Yes, so there's clear criteria, juniors will discharge the patients. There aren't clear criteria, they won't discharge them. And as it affects when this decision making with the consultants just going, yes, fine, they can go, as you put in there. And I think it also goes to show about senior sign-off of admissions. We have fewer admissions. You can't do that 24 hours a day, but most of our admissions arrive in the ED when there are consultants around. So what can we do around, if not seeing every patient, sign off admissions? And there are papers out there that show that twice daily consultant input can halve length of stay if it's done over the same period of time. And the thing for me is, I'm waiting for the national data on readmissions because someone went all the way loads of readmissions. I'm waiting for that. There's no evidence so far we've got that. I'll have that soon. And the second thing is I'm waiting for the national OPAL status, but everything we have is improved dramatically. So we went from OPAL 4 to level 1 in 4 days after a bank holiday weekend. We have never done that, anywhere close to that. So the question would really, if this is shown benefit, is what could we pull out of it, either an evidence to talk to people about changing practice, or to dispel any myths that's actually, if we increase discharges, and with readmissions data I'll have very shortly, there's no increased readmissions. Actually, we know the harm of deconditioning. There's no significant readmissions. It's probably fairly safe to say that this is a process that results in shorter length of stay, reduced risk, reduced outliers, reduced ambulance delays. This can only be beneficial unless we have data to say otherwise. And I'll stop there and just increase some people's thoughts, really.
Thanks, Ben. Thanks so much. I was scribbling away in the chat, but I think it really endorses that twice daily board round, that touch point, but combining it with clinical criteria for discharge so that the consultant doesn't need to see every patient each time. They can simply kind of go through the criteria and how is this progressing, and empower their staff to understand not only that they need X, Y, Z tests, but what is needed for it to show for that patient to go home. And also that change from it saying a hemoglobin of a precise figure to hemoglobin improving is sufficient for them to go home. That change in the patient needs to be completely fixed to go home to they need to be ready to go home to continue their improvement at home. And I think that John Day speaks really eloquently about that perfect point where the benefits of hospital starts definitely outweighing the risks, but there is a point where the risks start outweighing the benefits, and that's when they need to go home or to their original place of care. What do people think? Giles?
I guess being very cognizant of it's not replicable, because this was almost a test of change forced upon us. It does really focus the mind on what we would predict would happen in those circumstances. So it works really well as a test of change, but within the parameters that we've got. So I suppose for me, the key thing here is how do we capture that in a way that does create momentum and does share that conversation widely, because it would almost be criminal not to just revert back and say, well, that was outside of our control, but which elements of it aren't outside of our control? Which elements can we embrace? So I guess there's a challenge for all of us there on how we articulate that to our trusts or trusts that we're working with, and use it in a way. And clearly Ben's data is quite raw there at the moment. He's pulling together the presentations, wants to get that readmission rate fed into it as well. But it's really powerful, it's really compelling, and I just love the fact it does tell us what we thought potentially could happen. But it starts to form an evidence base.
And I think the other thing my thoughts are is the other thing we have to be really mindful of is we're a training profession. We're vocational, people are learning on the job, and that's what junior doctors are there for, as well as service provision. And there's something around what we wouldn't want the message to be is that consultants need to make all the decisions and juniors don't do anything, because there is something around that development piece. And I think that's where the clinical criteria for discharge comes in, where it's more the consultant showing the inner workings of their brain out loud so that the juniors can learn from that, and also empowering the juniors to go off and do the ward round and come back with their viewpoint, and the consultant critiques that so that it's a learning exercise with some critical challenge about is the risk really that they need to come, you know, do they need to be in? Could they go home? But I think we would need to caveat heavily around the fact that it is a training organisation, and it's the reason we can't all be working at the top of our licence all the time, because there is an element of development that needs to go in. So Ben, that would be my sort of
I've got
thought.
that. Thank you. Thank you. And in terms of sharing it, our plan is to get the readmission data, to get the national OPAL level status data, to say actually, and then try and, someone suggested an opinion piece, sort of EMJ, BMJ type scenario, or just we could probably do ESIS. It might be useful, because actually I think we should share it, because otherwise it will be lost in the, oh, wasn't it great? Yeah, but I can't do that. Never mind. It's what what could we pull out of it as, or to test more. What could we? And my Q said something interesting. She said, "This is interesting because you tell me everyone gets a twice daily consultant review when we're on OPAL level 4, and everyone gets a consultant sign off of admission, but we never go from OPAL 4 to OPAL 1 in 4 days. We usually go 4 to 3 if we're lucky, or 3 to 2 if we're lucky." So I find this interesting, because what we say we do versus if you've got to stand on the ward and do it because you're there, was a sort of a little bit of a dig, but a valid point as well. I think was a got Michelle.
I think it's really interesting. I worked clinically in ED during the strike overnights to support, and absolutely noticed that patients were staying in ED for far less amount of time. The non-admitted performance in NGH ED increased quite dramatically, but we actually had far less DATEXs submitted across the trust. So I think harm across the trust actually reduced, which is really interesting. Like to see about complaints and things, because people just felt, I don't know, I don't really want to say safer, but that it looks like practice was indeed safer, and patients had a better level of care during, and I know it's not replicable, because my husband is a consultant in ED, and there's no way he would be wanting to work nights all the while. But it's definitely food for thought, and the actual impact on patient safety was really, because I know everybody was so concerned about it, about the impact, but actually it seems that it's been a positive impact. So I don't quite know what we do about that.
No, it's an interesting point, isn't it? Yeah, it's a challenge. That side of it's a challenge, because clearly it would be safer to have more senior people around, but what can we learn from that? I always think, how often are these things discussed with people on call? I think that would be, I come in the morning on call and people, why didn't you ring me? If you'd rung me about that, I'd have, well, I thought I could. No, you ring me. That's what I'm on call for. And some of this stuff could be done by, that's what one thing is, Nikki.
Thanks, Ben. I'd put a message in the chat, but is this all age, the data, is it all age, or does it include children and young people as well?
So the ED data will include all ages.
Okay.
Because it's all like, yeah, all, yeah. I don't know about some of the other stuff, but yeah, most of that's ED. It's national ED and ambulance activity, so it should be
all age. Okay, thank you.
Thanks so much, Ben, for coming. It feels like a natural segue to move on to Ros and updating around clinical criteria for discharge and criteria-led discharge, both which Ros has been leading on and has lots of updates, including papers that are being written because of the amount of all of you guys that have taken part so far. But I'll hand over to Ros.
Thanks, Imogen. So we wanted to talk to you about the criteria-led discharge work as one of the tools in the toolkit. That is a plethora of tools that could be used to tackle harm. So we just wanted to make sure that this group were cited on the work that's happening, give you opportunities to get engaged if that's what you want to do. And I'm going to send out the slides I'm going to share, because there's a lot more detail in the slides, but I'm just going to talk about a couple of the slides if that's helpful. So I'm just going to share my screen, Imogen, if that's all right.
Thanks.
And go on to slideshow. Oh, you see that?
Yep.
Lovely, thanks. So criteria-led discharge, as many of you are clinicians for a number of years, is not new. However, it's not embedded, like many of tools in our toolkit is not embedded, and we wanted to understand why. So about a year ago in the Midlands, we started a piece of work initially with one of the hospitals in our Midlands, UHCW, who were already doing some work on criteria-led discharge. And rather than launch an improvement programme that may not work yet again, we wanted to understand what was going on with criteria-led discharge, what the opportunities were. So we scoped all of our systems and every acute provider in the Midlands to understand, did they have a programme of work happening already? What scale was it at? So was it, 10 being implemented, we've got evidence that it's all singing, all dancing, bells and whistles, to 1, we've got an idea, it's just started. The majority of programmes of work, with the exception of, I'd say, 2, were at that lower end of the improvement scale, and that was those that were doing it that were telling me this. So we wanted to know what we could do to help, and we worked with a group of clinicians, so people from ICSs, acute providers, across the Midlands again, to understand what would help. And they said, we need to get people engaged in this. We need to get people talking about it, because we do believe our gut instinct says this is going to make a difference, but we need to get the clinicians involved. So we did and developed a point of prevalence survey. So UHCW had started this process, and they got a very rudimentary point of prevalence survey. And we developed it again with clinicians across the Midlands. So we did the first one May last year, and we had, I think, about 18 organisations involved across 7 systems. And then we did the second one in October. And again, we refined the tool with the help of the clinicians out there that were doing it. It was completely voluntary. No one had to take part, and despite the first one taking place, after a summer, after probably a really terrible winter, and actually what people told us last summer is things didn't let off, like they previously did in summers gone by, but they still got engaged. And in the October one, we had 32 wards across 22 sites across 10 integrated care systems. So it was a real world study in real time, with collaboration with clinicians that were out there doing it, telling us what they thought would help. One of the purposes of this point prevalence survey is to get clinicians involved and engaged in the conversation. The second part is to understand what's the opportunity for criteria-led discharge within, your organisation or within that particular ward. So we had a number of results. It's embedded in a whole range of improvement work that is already happening. So we got Recondition the Nation, which we started last summer as well. Imogen, this tackling harm together, thinking about what are the opportunities for, for reducing harm across the whole patient pathway in and out of hospital. We've got the speed point of prevalence, you've got safer, you've got red to green, there's all sorts of tools. So this isn't, say, a standalone, it's an adjunct to. What do you need to make speed work? Well, you do need MDT engagement. It will help clinicians, understand what's going on in their particular ward or department, as well as the organisation. You want to look that wide. It will help clinicians who already do, private practice, for example, might already be using CLD in another part of their practice. So there's things that we could learn from that's already happening, within health, but in another setting. The things that we've learned, for CLD that is effective is that it's got to be really simple. It's got to be supported by an organisational policy or procedure. The documentation has to be really quick and easy to use. It can't be reams and reams, because otherwise no one will use it. So it's got to be one sheet, or it's got to be a digital solution. So in terms of when we'll do it next time, we're going to do the speed point prevalence in June. between the 13th and the 24th. And again, those that took part last time said we want several opportunities to take part, because if our organisation has a crisis that day, we want the option to say we're going to stop doing it because it's not working for us today, and we're going to do it on this particular day. So we're given lots of opportunities. We ask that it's one elective and one non-elective ward as a bare minimum, and the whole ward has to be done. We ask that 3 members of a multidisciplinary team undertake the survey, and that's to create that critical friend, professional challenge and debate across a range of clinicians. And we ask that 1 member is a clinical decision maker, so that you've got that real clinical knowledge and expertise. That has been in some cases an ACP, and in some cases it's a registrar or consultant, so it's unique to each organisation. It will take approximately 2 to 4 hours to complete, and there will be training provided. And again, the slides that I'm going to send out, give you all the information if you or your organisation choose to take part. In terms of results, I'm just going to stop sharing a moment when I figure out how to. Stop sharing. In terms of results we had in the October survey, it demonstrated that consistently over 50% of patients were suitable for criteria-led discharge in the opinion of those clinicians that were undertaking the survey. It was prevalent across all age ranges. It was prevalent across a massive range of specialities. And in terms of who could discharge, the views were predominantly a nurse or a junior doctor, on the ward. And what having clinical criteria for discharge empowered those clinicians to do that. So we didn't ask them to discharge on the day. We said, what's the opportunity? Interestingly, of those that weren't suitable, there was 3 top reasons. I don't know if you can guess what they are, but one was complex, and complex was a variety of things. It could be a complex discharge, so we didn't have a care setting. The person might be homeless, so we didn't have a next step for that particular patient. So in the next survey, we're going to break down that complex into complex health, complex social, so those sorts of reasons. The second reason was diagnostics. So we couldn't make a decision on the patient whether they could set a clinical criteria for discharge because they were awaiting a diagnostic test. I know clinicians, and John Day is one of them who really advocates clinical criteria for discharge, is that actually you shouldn't be doing a diagnostic test without a criteria set against it. What are you looking for? And see Ben nodding there. And the third one was really interesting, awaiting a doctor review. So there just wasn't enough information in the medical records for those 3 clinicians doing that point of prevalence survey to make a decision, because the plan, the journey for that patient just wasn't clear. So all of those need further exploration, but really interesting findings. And as Imogen said, we're publishing a paper, hopefully in the next 3 months, in the British Medical Journal for Improvement, around this topic, to share our findings and to share how the evidence base of how we develop the point of prevalence itself. So I'm going to pause there and just open for discussion, comments, questions.
I think you've stunned everyone into silence, Ros. Ros, I was just going to ask a question. If people did want to get involved and they wanted to share the information with their trusts and get the resources, should they email you? Is that the best thing? And would you?
So on the slide deck I'll send out, and I'll send it to everyone on your group, Imogen, there's a QR code to scan to take part. You do need medical director or nurse director approval, but we don't need to see that. You just need approval. And then it's a Microsoft Office form to register. Anyone that's registered will then be invited to training sessions. There'll be 2 a week for 4 weeks, so they'll just be quick half-hour sessions. It's not rocket science. It's an Excel spreadsheet, but we just want to talk through people the theory and experiences of others that have done it before.
And just to be super clear, they don't have to attend every single one of those. They just need to attend one. It's like there's just lots of options.
And it's just one member of the team that's going to be leading it, so they can then cascade that to. They want one organisation did it on 10 wards, and they just cascaded that information to relevant members of their team.
And talking of hierarchy, I know there's been some conversation in the chat box about that. I think one of the things the tool really helps with is flattening that hierarchy, because it kind of gives a tool that whoever's leading on it, if it's a nurse, to kind of say to the doctor or AHP or whoever else they're working with, we've got to do it like this, and this is how it works, and it kind of enables more conversation to happen on a kind of equal level. And it's been quite a good way of launching it or relaunching it in the majority of cases, because a lot of places have been trying to get CLD to happen for a while. Thank you so much, Ros, for coming and joining in. And it might be great to kind of follow up in another community of practice, just kind of an update and how things are going. That would be brilliant.
No problem. And I'll send the slides around to everyone, Imogen.
Thank you so much. I'm aware of time. What I would love now is to kind of move the conversation on a little bit to the Tackling Harm Together resources. So there's the video, there's the infographic around evidence, there is the poster, and there are some workshop resources. I wanted to share, first of all, case studies. Zoe can't be here today, but if I can share some of the learning that she has had from running a nursing workshop in Barnsley, so outside of the Midlands, but very much involved in creating these resources with us. Zoe is a discharge matron, and she has been really passionate about discharge ever since actually working in an A&E as a sister there, and being frustrated by not being able to get patients through out into the wards quickly, and so has moved to the discharge end. Oh, here she is. Hi, Zoe. There you go. Would you mind sharing, Zoe, since you're here? I didn't know you could make it. A bit about how you used the workshop.
Yeah, no, sorry, I were a little bit late. Yeah, so really interesting. We had a day out for nurses, so we took them off the shop floor and we took them to a hotel, and we did it was a patient safety day, so we were looking at several different things, but one of the breakout rooms we did on discharge, and so I utilized the video with just a couple of slides. Really good engagement. But I think the key was taking the nurses out of the clinical situation to have time to really think about the impact of patients. One of the key things we talked about was around nurses feeling like, you know, they're climbing a mountain every day with a backpack on, and we're just asking them to do more and more work, and actually they've not got the time to do that. And it's about selling that theory of that one extra discharge supports so many other patients. So we had some really interesting conversations about that, and I think a lot of people were just really are always just really focused on that patient in that bed in front of them, and don't consider sort of the wider group of patients that we've got within our organisation and our system. So yeah, really interesting, and some really positive conversation came out of that.
Thanks, Zoe. And I know one of the things you said that has worked also really effectively is that in parallel, you've been doing an internal delay programme of work, again, to support staff in cutting down those internal delays. And you also mentioned about the safer kind of visual digital dashboards. Would you mind just explaining a little bit about that?
Yeah, no, that's fine. So we've got an electronic whiteboard that we're based on the safer principles. And as part of that, we fill those in daily at every morning and afternoon board round. And then to take that a little bit further, so the next step to that is creating a ward accreditation dashboard, so we can see at a glance on the entrance to every ward how well the ward's performing against those safer principles. So, you know, how many patients have had a senior review daily, how many discharges have we got before midday, how many golden patients have we got. So really visible and giving the ward some ownership, also a little bit of competition in there with that. So that's working really well. And then we're doing a really big project on the patient journey. So we're looking at the patient journey from start to finish, so from admission, from ED right through to the end to discharge point, and we're looking at every service and pathway that's possible for that patient and every delay. Some of the delays that we found are quite big, quite significant delays, 24, 48 hours, but some are really small and some are only 30 minutes. But when you look at the amount of patients that go through that pathway and can enter that delay, even if it's 30 minutes, it's a really big impact on that patient journey. And then we're looking at obviously how we put changes in to reduce those delays. One of the really interesting things after our meeting yesterday was I actually pulled 10 patients' notes just to come on about criteria-led discharge, just 10 patients from one ward to look at. And actually 2 of those patients, I found that we could have saved 4 days on each of those patients just using a criteria-led discharge. So, you know, that's 8 days for 2 patients, and you know, that's massive. And one of the things for us is we know that if we could cut length of stay down by 1 day, we wouldn't have to have any escalation beds open, we wouldn't have to have extra patient and ward areas, dining room areas, or, you know, be having to open full escalation wards. So I think it's how we sell that back to staff, to give staff the time and the resources that they need and the patient's time. So that's really important.
Thanks so much, Zoe. And it ties back to what was said earlier by Michelle about the fact that during the junior doctors' strikes, they had fewer datixes and the patients had shorter admissions and got through, and the flow was quicker. And I think you were saying as well, like telling that to staff that they'll have less of that kind of paperwork of incidents, etc., to deal with. So
yeah, definitely, and especially for the lead nurses too in their role. You know, if we know that we've got a reduced length of stay, we know that we've got less harm to patients, we know that we've got less datex as RCAs to investigate. So it's freeing that time back up for staff to actually spend it with the patients. Yeah, so really interesting. A lot of work. We're really busy, but we'll keep updating on it.
And so you were also explaining you are sharing with the other trusts in your system now to try and get the momentum built across the system, is that?
Yeah, that's right. And actually, I've just had a meeting with Bristol this morning, so it's a resource that I'm going to share with them too. But yeah, we've shared it with some local trusts, the video, and we're just waiting for some feedback now on how they use it in their areas.
Thanks, Zoe. Thanks so much. I'm very glad you were able to join. So I don't know about any of you, the rest of you on the call. Has anyone thought about using the resources yet? And if not, kind of what's stopping you, what's getting in the way? Who else would you need to get on board? That kind of thing. It'd be really useful to open up. Penny.
Yeah, hi everybody. I'm Penny. I'm working Nottingham and Nottinghamshire ICB. I must confess that I haven't used the result. I've obviously looked at them, but I haven't used them in terms of sharing them, because it takes me a bit of time to get to a point where, okay, what am I going to do with these? But I can absolutely say when I was first introduced to them and accessed them, because the harms issue is one that's been kind of, you know, causing me problems for quite a long time. I emailed Rosa, who's our chief nurse, and I said, this kind of workspace, it's like seeing a picture of an elephant after someone's been trying to describe it to you for the last 12 months. You know, it just brought everything together, and made me think, I feel like I've had an empty space and now I don't have an empty space anymore. And then it's just working out what, you know, which bits to pull from that and kind of bring into our system. Where we've got, I'm not sure who else is on the call from Nottinghamshire, but we've got a lot of different things going on within our different partners, and I think my next step is going to be about trying to map that essentially and bring it together, because there's such a lot of good work going on and a lot of data being captured. So that, hence I said to Ben, you know, it would be good to kind of map this across the system. I'd like to have a system view of all the work that's going on so that we can try and coordinate it a bit more. That's my next step from that, and that's what I'll be using the resources for.
Thanks, Penny. And I think my only advice is, if sometimes something seems too big, is almost start small, like, but you know, find one willing adopter on one ward and try it with those nurses or the MDT. That, you know, maybe sometimes trying to think too big is just too hard with this stuff. But
yeah.
But I look forward to following your journey and hearing more.
Thank you.
Kath.
Again, very much like Penny said, I have seen it, not read it properly. We'll be reading it properly now, but we've got quality very high on the agenda on our UEC delivery portfolio. So I think we've got a real opportunity to use that way in within the system to start sharing these. And whilst everybody's been talking, poor Steve Fawcett on the call is getting lots of messages separately from him. Can we do this and can we do that? So very, very keen to get that started. And I think probably from a system point of view, and I know Anne-Marie's normally on here, so I know that the trusts are doing a lot of this work as well. So we, like Penny says, we need to know who's doing what where, pull it all together, and then we can see where we are.
Brilliant. And I think the other set of resources, other than Roz's great work, is also Fiona Lennon's Recondition the Nation is another set way of kind of hitting this from a slightly different angle. And also Dee Henry's Bringing Pathways Together work, which I can share the link for that as well, which is all around creating a credible alternative to hospital admission, like really joining up community services, because I think that's the other part, isn't it, of if you're not going to admit someone or you're going to send someone home earlier, what is the offer for them at home? And also we know that there's a lot of like over diagnosis of care needs at discharge, and often that care package isn't needed to be as high as is what the patient's discharged with, and a lot of that is not quite understanding or knowing what the offer is in the community. So I think that's another strand to this that is really important to kind of match up with the system view. Thanks, Rachel. I know you've popped in the chat as well that you're looking to signpost to it as well. We are vaguely thinking of trying to create some snippet videos or podcasts of people like Zoe that have actually like run with it, so that we can all learn from people that have like done it and learn from it. Like my particular learning from Zoe was actually the fact she used that slide in advance of the video of the nurse with the backpack and really kind of brought it back to what it's going to mean for the staff doing it, and that the improvements it will make for the staff, as well as being honest about the work it will create for them, but the savings of work as well. Because I think at the moment we just have to be so aware, don't we, of the environment our staff are working in, and it's not going to work if we purely make it about the patient. It's got to be about that marriage, isn't it? And the reality of that. And also we know from evidence of Professor Michael West, etc., that if staff are happy and are feeling supported in work, they're going to provide the best care. So I think it is about that, starting with how we can help our staff. And that follows on quite a lot from the last community of practice with Chris Moulton, talking about that internal demand that's created by poor processes or poor IT and trust, etc. And how can we really help our clinicians make things as easy as possible for them to do the right job in their trusts or their systems. I know we said 45 minutes, so we've got a couple of minutes left. I did say I was going to share some Hewitt report stuff, but to be honest, it's a set of slides that I can add to the resource pack, and I don't want to take up your time with it now. But thank you so much for joining. Is there anything else you guys think we could be doing to help you use those resources? Any other future topics you'd like in the community of practice? Please scribble it in the chat or put your hand up now if you've got any thoughts. Well, we'll keep you posted as to what we're up to try and keep supporting you. If it helps at all to have any one-to-one discussions to kind of chat through how you might want to use them or anything like that, please do reach out to me. I'll put my email in the chat. Thanks so much for joining. The other thing is, please spread the word about this community of practice. The more the merrier. And our WhatsApp group as well, which you can get the QR code to join on our Futures site. So thanks very much and have a great day and good luck.